Hi, it's Ben from Pulse Notes. In the next 10 minutes, we're going to teach you everything you need to know about the jugular venous pressure. So assessment of the jugular venous pressure, or pulse, forms part of the cardiovascular exam, and we often shorten this to JVP. So we assess the JVP by looking at the jugular veins within the neck, and this helps us determine a patient's fluid balance. So are they dehydrated or are they overloaded? So we do this as the JVP is an indirect marker of central venous pressure. But what exactly does this mean? So central venous pressure refers to pressure within the thoracic vena cava near the right atrium. So right atrial pressure is quite a good estimation of central venous pressure due to its proximity to the vena cava. So central venous pressure is a surrogate marker of right ventricular preload, which essentially refers to ventricular stretch at the end of diastole. So if we increase preload, so increase the amount of blood stretching the ventricle at the end of diastole, this increases pressure and causes the JVP to rise. So the normal central venous pressure is around 1 to 8 millimeters of mercury with a mean of about 4. So the jugular veins are connected to the right atrium of the heart via the superior vena cava, and they're important for returning blood from the brain, face and neck. So some functional valves do exist between the superior vena cava and both veins, but the CVP can be estimated because pressure is exerted through these functional valves. So here we see a diagram of the veins in the neck, the internal jugular vein and the external jugular vein, and their relationship to the sternocleidomastoid. So the internal jugular vein runs from the jugular foramen to the base of the neck. The internal jugular vein runs within the carotid sheath, deep to the strap muscle known as sternocleidomastoid, and it joins the subclavian vein to form the brachiocephalic before becoming the superior vena cava and entering the right atrium of the heart. So it's a much better marker of central venous pressure because it has a relatively straight path, and this is the vein we're looking for in the neck when we're assessing on our clinical examination. So the external jugular vein runs obliquely across the strap muscle and enters the subclavian vein. The external jugular vein is formed by two joining veins at the posterior angle of the mandible, and it takes two sharp turns during its course, meaning it's less reliable as an estimate of central venous pressure. So when we examine the jugular veins, we can look at two things, the height and the waveform. So the jugular venous height refers to the column of blood, the maximal height it reaches within the neck. It reflects right atrial pressure, and it's typically raised in conditions such as fluid overload or obstruction. The waveform is a characteristic trace, and it's due to changes in the right side pressure of the heart during the cardiac cycle, and we get this typical double impulse waveform that we call the venous pulse. So assessment of the JVP can be very challenging in clinical practice, and it takes time to learn, so don't be disheartened. Here's some key principles. We want the correct approach to start with. We want to approach the patient from the right-hand side, and we typically assess the right internal jugular vein. We then want to correctly position the patient. So it should be lying supine at a 45-degree angle with the neck extended and the sternocleidomastoid slightly relaxed. We then want to turn the head slightly to the left. We then want to identify the internal jugular vein. So if it's very elevated, we may see it near the top of the ear or near the earlobe. Or if it's very low, we may see it just appearing at the medial end of the clavicle, often between the two heads of the sternocleidomastoid. We then want to consider a light source to help us better assess the JVP. So this involves shining a light across the neck to improve visualization, but it's important that light is tangential, so coming from a low angle to the object we're trying to see. And then finally we measure the JVP. So this is the height of the internal jugular volume blood column. And that gives us the height of the JVP, and then we combine that with a standard measurement of 5 centimeters to form the central venous pressure. So here we see a diagram showing this measurement. So we have a patient lying at a nice 45-degree angle, and then the measurement we make is between the sternal angle to the top column of the internal jugular vein. And typically in healthy individuals, that height is less than 3 centimeters. We then combine this measurement with 5 centimeters, which represents the distance between the right atrium and the sternal angle, and that gives us the central venous pressure. So one top tip is if the jugular venous pressure is very elevated, the pulsation may cause the lower part of the earlobe to pulsate or wiggle. So if you're expecting someone to be fluid overloaded, look straight for the ear and see if you can see that characteristic wiggle. So one important clinical sign is hepatojugular reflux. So this involves applying firm pressure over the right upper quadrant to transiently increase the jugular venous pressure even in healthy individuals. So to do this, we apply firm pressure over the right upper quadrant for at least 10 seconds, and in doing so we observe the internal jugular vein. So we should see a temporary rise for 2 to 3 beats in the jugular vein, but the test is considered abnormal if the JVP remains elevated for at least 10 seconds of compression. So it can be very difficult to differentiate the jugular venous pulse from the carotid pulse. So we know that the JVP has a characteristic double venous pulsation, but despite this feature, it can still be really difficult to differentiate it from that arterial pulsation of the carotid artery. So this table summarizes some of the key differences. So with the venous JVP pulse, it's a double pulsation. It falls with inspiration due to a decrease in intrathoracic pressure, allowing blood to go into the pulmonary circulation. If we compress lightly at the base of the neck, it will cease to exist. And it's very difficult to palpate it. With the carotid pulse, it's a single pulsation. There's no change in inspiration. There's no real change of compression lightly at the base of the neck, but it's easily palpable. So the main abnormality listed from the JVP is an increase in height that we call a raised JVP or an elevated JVP. So a raised JVP has 3 predominant causes you need to know about. One is right-sided heart disease, so something like right-sided failure, pulmonary hypertension, or right-sided valve disease. In these cases, there's an increase in right-sided pressure, leading to a rise in the JVP. The second is obstruction, such as a tumour or thrombus, so a clot within or adjacent to the superior vena cava. Any blockage to blood flow within to the right atrium can lead to a rise in the JVP. And then finally is a generalised fluid overload state, such as with renal disease, liver disease, or excess intravenous fluid. All these conditions can lead to a rise in the JVP. So here we have the classic JVP waveform that we can see on the right-hand side. So the JVP waveform is divided into 5 typical components with 3 ascents and 2 descents. So on the right we see that nice waveform, our 3 ascents, so upstrokes are A wave, C wave and V wave, and our 2 descents are the X and Y, of which the X is divided into 2 components, X1 and X2. So let's have a look at how that waveform is created with the cardiac cycle. So here we have a nice diagram of the heart showing all the heart chambers, the pulmonary vein, pulmonary artery and aorta. Looking at some more labels, we can see the internal jugular vein, our site that we want to look at, the subclavian vein, how they join together to form the brachiocephalic vein, the superior vena cava, which then enters into the right atrium, and below we see the inferior vena cava. So now let's think about how that waveform is constructed. So we start off with our nice JVP waveform, our 3 ascents and our 2 descents. So as we said, the JVP waveform has 5 characteristic changes, and these reflect pressure changes in the right side of the heart during the cardiac cycle. So initially we have atrial contraction, and that forms the A wave, the first ascent. So during atrial contraction, blood is forced from the right atrium across the tricuspid valve into the right ventricle. Increases in the right atrial pressure cause a temporary pulsation in the JVP, which is seen as the A wave. Then we have atrial relaxation. So this is the first X descent. So the first descent occurs due to relaxation of the right atrium after atrial contraction. This causes an initial drop in pressure and allows blood to fill from the superior vena cava. Following this, we have ventricular contraction, which forms the C wave, the second ascent. So forceful contraction of the right ventricle leads to upward motion of the tricuspid valve that bulges into the right atrium and increases right atrial pressure. Then we have the second X descent. So this can be remembered as extra space. So this is the hardest to conceptualize in the JVP waveform. But essentially, as the right ventricle continues to contract, it takes up less space. This increases the available space within the pericardium that allows the right atrium to expand and fill with blood, therefore dropping the pressure in the jugular venous pulse. We then have the V wave. So this represents atrial volume increases. So the right atrium continues to fill with blood against a closed tricuspid valve. As this occurs, pressure within the right atrium slowly increases to a maximal point seen as the V wave. And then finally we have atrial emptying, which is the Y descent. So as right atrial filling continues, pressure increases. The tricuspid valve then opens, leading to rapid ventricular filling prior to the onset of right atrial contraction. And therefore this is seen as the Y descent. So this completes all the different components of the JVP waveform during the cardiac cycle. So thanks for watching. I hope you've enjoyed our talk on jugular venous pressure. For more great information, check out the app.pulse-notes website, where you can read notes, answer questions, or watch more excellent videos like this. So thanks again.